In JACC, a paper on the incidence, predictors, and impact of late bleeding after TAVR. That's the topic, and I'm with Dr. Philippe Genereux, who is director of the Angiographic Core Laboratory at the Cardiovascular Research Foundation and also an interventional cardiologist at the University of Montreal. Okay, why did you do this paper, first off? Because this is an interesting topic.
Yeah, so the goal actually was really to see, there's no data, first of all, on the incidence of late bleeding after TAVR. So these patients survive, everything go well. But between 30 days and 1 year, we don't know if they bleed. We don't know. There's no data about that. And the reason why it's so important is because we don't know yet what is the best and the most appropriate antiplatelet therapy or anticoagulation strategy for this patient. So to know the incidence and actually the impact of bleeding, late bleeding after TAVR among the patients who survive, it's important to inform future trial. And to say, well, it is 6%, so what is the mortality, as I said, and what is the benefit that we can expect for new therapy? So that was the main reason why we decided to do this retrospective analysis of more than 2,500 patients from partner experience who underwent TAVR. Really important to design trial, to know what is the rate, and to improve patient and outcome.
So what did you find when you start analyzing that much data?
Yeah. So that was very intriguing, actually, because we find that 6 to 7% of the patients, when they survive TAVR, experience major bleeding, not minor, but major bleeding, either leading to death, rehospitalization, or transfusion. And actually the main cause of bleeding was GI. 30%, more than 1/3 were from either upper or lower bleeding. And we know that there's some association with some angiodysplasia, with AS that usually go away. But that's very important to know because 1/3 will bleed from the GI. The other two types of bleeding that were more frequent was neurological bleeding. So important bleeding that is very scary and may explain half of the stroke after 30 days. So you bleed in your brain, maybe because of the anticoagulation too strong or the antiplatelet therapy. The third one is very interesting is the fall, traumatic fall. This patient, 80, 90 years old, decreased mobility, frail. So the sequence is they fall, they hit their head, they bleed, they get hospitalized and they die and they lose the benefit of the TAVR that we invest in them. So that was the first finding. What was the type of bleeding? After that, we looked actually at the predictor of bleeding, and that was very interesting because we found that the strongest predictor of major bleeding after 30 days were two. The moderate to severe PVL. Actually, it was a little bit intriguing at the beginning, but there's a rationale behind that. And the second one is the presence of atrial fibrillation, so the use of warfarin. So two hot topics. After that, what we found is that when you bleed after 30 days, major bleeding, you have twice the chance of dying. So about 35% chance of dying at 1 year when you bleed, compared to 10% when you don't bleed, 15%. So very important, we need, if you want to improve outcome of the patient after fixing their valve and they are very healthy and at 45 days or at 6 months they bleed, they will die more. And the most interesting finding is among the subset of patients with AFib. If you have AFib and you bleed, 50% chance of 1 year of dying. Clearly illustrated the gap in the literature, what we need, maybe this patient with AFib and high-risk profile with AS and ongoing TAVR, maybe they need something else than anticoagulation. So that was the main finding, and truly I think that's give meaningful data to inform future trial, to design trial about how can we decrease bleeding on this AFib patient. Should we drop the aspirin? Should we put left atrial occluder? Or should you only give them warfarin? So really this is crucial, and I think that was the main finding.
What's the clinical message here? If you've got patients, and that's the kind of risk you're seeing after 30 days, what do you tell the clinician?
Yeah, so that's an interesting question. First of all, the GI bleeding is very predominant. So if we're about to give aspirin and cianopiridine, maybe we want to use gastroprotection and be careful with them. Maybe we want to do prevention. Maybe we want to make sure that there's no chance they're going to bleed with a colonoscopy, with a gastroscopy before. The second thing is more for the atrial fibrillation patient. We need maybe to stop this triple antiplatelet therapy. They really need aspirin. They really need clopidogrel with the TAVR. This is all unknown answer. There's a lot of trial going on. One is the main one is the one led by Joseph Redescabo from Quebec, the ARTE trial that will give us meaningful insight. But clearly, we need more data, and for the community, we need trial to assess this to decrease the bleeding, because we're pretty good to fix the aortic stenosis, and now the patient go home and now they bleed and they die. So we need to address that. And the third message I would say, which for me is very interesting, is the moderate to severe PVL linked to bleeding. So, of course, we know that moderate to severe PVL has been associated with mortality in many data sets, but we never know why. Is that because the LV go down? Is it because the LV doesn't recover? Is it because these people die of heart failure? I don't think so. Actually, what we show is that mainly they bleed also. Is that only a marker of a sickness, or this is a causality that moderate to severe PVL with all the turbulent flow creates some breakdown of the big molecule, the Van Wert factor, so they are more prone to bleed? So that's interesting. That's really mandate further investigation, and maybe here some interesting data to improve patient care and tailor therapy based on maybe surrogate marker.
Well, the paper is by Genereux et al., and please, we've given you a citation a couple of times during the video. Please look at the very end for the full citation from Jack. For CardioSource World News, I'm Executive Editor Rick McGuire.